The indications for the FAST exam include trauma, where you will be looking for free fluid in the abdomen and the pleural space, which in the setting of trauma is presumed to be blood. You will use it to look for pneumothorax and hemothorax, pericardial effusion, and to assess basic cardiac function. There are questions about whether this is better used in the setting of severe versus mild trauma, which will be affected by the resources available to you. And the FAST exam becomes even more important when CT scan and labs may not be available. Other indications for the FAST exam can include nephrotic syndrome assessment when looking for ascites, or as part of the general ultrasound performed for undifferentiated shock. The first thing to decide when performing the FAST exam is which probe you're going to use, which will be influenced by which probes are available to you. For the abdominal and cardiac portion of the exam, either the curvilinear, also known as the abdominal probe, or the phased array, also known as the cardiac probe, are appropriate and will give good images. When performing the anterior chest view, the more appropriate probes will be either the curvilinear or the linear probe, as the phased array probe will give less clear images of lung sliding. There are 6 places that you will scan when performing the FAST or extended FAST exam. They include the right upper quadrant, which is done at the mid-axillary line on the right side, pointing posterior. The suprapubic view, which is done in both transverse and sagittal planes. The left upper quadrant, which will be performed at the posterior axillary line, pointing posterior. The subxiphoid view of the heart, which will be done just below the xiphoid, looking up into the chest. And then the anterior chest, both right and left sides. The exam starts typically in the right upper quadrant at the mid-axillary line with the probe marker pointing towards the head. Fan through Morrison's pouch, which is the region between the liver and the right kidney, shown in the video here. Slide down on the patient's body to get a good view of the tip of the liver. Look at the spine to see if it extends above the diaphragm, which would be suggestive of a hemothorax. When fanning through the right upper quadrant, you can see that the spine is not shown above the diaphragm, suggesting there is no hemothorax, and there is no free fluid seen between the kidney and the liver on the right side. In this image, there is not a distinct view of the liver tip, which is the other important part of the liver to see. In the right upper quadrant, as you fan through and look at Morrison's pouch, you can see that rather than a complete white line between the liver and the kidney, there are black areas that you can see in that interface of Morrison's pouch, which represents free fluid. Certainly, when there is a large amount of fluid, you will see the tip of the liver floating in a large area of black, which is more obvious in this picture than in the prior images. Here is a more close-up view of the tip of the liver, and you can always feel comfortable changing your depth in order to get a better look at the tip of the liver, where here is shown some fluid only around the very tip. The pelvic or suprapubic view attained during the FAST exam consists of looking through the bladder in both a transverse and sagittal fashion. In the transverse view, the bladder should look like a square or a piece of toast, and you can see the hand placement on the left side of the screen with the image that is acquired when fanning through the bladder on the right side of the screen. This is a normal image. In the sagittal view, the bladder has a more triangular shape. The probe marker is pointed towards the head in this view, and so the left side of the screen in the image represents where the patient's head would be. As you fan side to side, you are able to see the entire area behind the bladder to look for fluid. We turn down the gain in order to eliminate the brightness that exists behind the fluid-filled structure that is the bladder, because you are largely looking beneath the bladder or behind the bladder for free fluid. Make sure that you fan all the way through the bladder, through the pelvis, from the top part all the way through the bottom part of the bladder. The image on the left shows normal findings, fanning through the bladder all the way through in a transverse view, whereas the image on the right demonstrates free fluid in the pelvis behind the bladder. However, you can see the free fluid is only visible towards the end of the image and demonstrates the importance of fanning through. The free fluid is seen towards the tip of the arrow. The video on the left shows a sagittal view with the bladder being shown towards the right of the screen and a large amount of pelvic free fluid on the left side of the image. The image on the right, on the other hand, seeing a large amount of free fluid in a female patient, which is outlining the uterus. For the left upper quadrant view, have the probe marker pointing towards the patient head. And you want to be just posterior to the mid-axillary line, slightly more towards the head and slightly more posterior than you are on the right upper quadrant view. Try to look above the diaphragm for a hemothorax and look at the tip of the spleen. Look between the spleen and the diaphragm. Try to view the splenorenal space between the spleen and the kidney, although that is not the most likely place for fluid to go. Fan through the entire structure. The image on the left shows no free fluid in the left upper quadrant, with the spleen neatly tucked against the diaphragm. The image on the right, on the other hand, shows free fluid around the dome of the spleen, which is the black area around the dome of the spleen next to the diaphragm. This image also demonstrates the spine going above the diaphragm, demonstrating that there is free fluid in the left pleural space. The image on the left shows a normal left upper quadrant. You can see the stomach actually come into view before the kidney does, which can look like an abnormal part of the spleen. However, as we fan through, we see the spleen is intact and there is no free fluid. On the other hand, the abnormal image on the right side sees free fluid predominantly at the spleen tip and around the splenorenal recess. For the subxiphoid part of the exam, you will be looking up through the patient's liver into their heart with the probe marker towards one side of the patient and generally having the probe tilted somewhat to the patient's left. The RV will be the closest chamber to the probe, and you often have to turn up the gain compared to looking at the other parts of the exam and may need to increase the depth. This is the typical subxiphoid view. You can see the chambers listed here with the LV being the left ventricle, RV being the right ventricle, RA being the right atrium, and LA being the left atrium. You often have to flatten the probe against the patient's abdomen, which can be uncomfortable if they have abdominal pain, in which case you may have to try a different view of the heart. This view does not show an effusion in still, but we are not fanning here. The image on the left demonstrates normal findings as you fan through in the subxiphoid view. You can see that there is no fluid above or below the heart, as represented by a lack of hypoechoic lines around that area. The image on the right, on the other hand, you can see that there is dark space both above and below the heart, with the area above the heart being between the liver and heart, which is the most sensitive area to look for an effusion in the subxiphoid view. Through multiple views of the heart here, in the parasternal long, parasternal short, apical, and subxiphoid views, we see a global effusion represented by dark black fluid all the way around the heart. For the extended fast, the views of the anterior chest, you will hold the probe with the probe marker pointing towards the patient's head in a sagittal orientation. Look at multiple rib spaces, and on the left you may need to slide up and out in order to avoid the heart. Between two ribs, on the right side of the screen, you can see the dark shadowing, which represents a rib shadow. At the top of the screen, there is chest wall soft tissue and muscle. What is pointing to the pleura is the bright white line between the two rib shadows, with the rib shadow off screen to the left, and then reflections of the pleural line down below, which are referred to as A lines. The image on the left shows normal lung sliding. You can see the reflective pleural movement between the two rib shadows, whereas the image on the right, while the probe is moving a little bit up and down the chest, you can see that there is no shiny movement of the pleura itself. Lack of pleural sliding in the right context should be concerning for pneumothorax, but can also represent apnea if there is no lung movement on that side, or can represent a bleb in the right type of patient. The lung point shown in this video demonstrates lung sliding to the left side of the pleura that comes in and out of the screen, and a lack of lung sliding on the right side of the pleura, which extends as the sliding goes off to the left. This is called a lung point and often represents the spot where the pleura is touching and then separating at the edge of the pneumothorax. Make sure to view the tip of the liver in the right upper quadrant, as sometimes this is the only place you will see fluid. This is sometimes done by rocking towards the patient's feet, sliding towards the patient's feet, or fanning or even sliding anteriorly towards the patient's front. In the left upper quadrant, remember that it is more likely to see fluid above the spleen, between the spleen and the diaphragm, than it is between the spleen and the kidney. However, it can be difficult to visualize this area. You can try and have the patient take a breath to move the spleen down. In the pelvic view, remember to turn down the gain, as the brightness underneath the bladder can obstruct the view of fluid. This brightness is caused by the fluid inside the bladder accentuating the sound waves, and if you turn down the gain, it can be easier to see behind the bladder. On the left side, pericardial movement can be easily confused for pleural sliding. The following practice case illustrates how the FAST exam can be used in a clinical setting. In this case, you have a 3-year-old boy who presents to the emergency department with vomiting and abdominal distension. There is bruising noted to his extremities, which makes the provider curious about the possibility of trauma. The patient's temperature is 37 degrees with a blood pressure of 105/65, a heart rate of 120, and a respiratory rate of 30, with an oxygen saturation of 97% on room air, which are overall unremarkable vital signs. As part of the initial assessment, you do a FAST exam and get the following images. Interpreting these images, we see on the right upper quadrant view, now shown at the top, there is fluid seen in Morrison's pouch between the liver and the kidney. There is also fluid at the tip of the liver. In the left upper quadrant view, in the middle, fluid is seen over the dome of spleen, but there is no obvious fluid in the pleural space. In the pelvic view on the bottom, we can see a small amount of free fluid posterior to the bladder, shown in the sagittal view. After the FAST exam was done, the patient's blood pressure dropped to 70/30 and he became tachycardic. He was rushed to the operating room, where he was found to have a large liver laceration with ongoing bleeding. This is a demonstration of how a positive FAST exam combined with hemodynamic instability can be an indication to go to the operating room. In summary, the FAST exam and extended FAST exam can be used in the setting of trauma, shock, or in patients with nephrotic syndrome or other reasons to have effusions that you may want to look for. It is also a good way to generally familiarize yourself with ultrasound and with a variety of modalities of using ultrasound to look at various organs.